Good evening. আমি ডক্টর কস্তুরি দাস, পেশায় ডাক্তার। আমি একজন রেডিওলজিস্ট আর আজকে I'll be going to talk on radiological imaging in COVID from the page of Federation of United Doctors. I will give my live talk. এবারে to take my talk forward, I will continue my discussion based on some salient points. Number one, how evaluation of the disease is helped by radiological imaging. Number two is prognostication. What is prognostication? The final outcome of the patient. How radiology can help in prognostication. একটা পেশেন্টের ফাইনাল আউটকাম কি হবে সেটা আমরা সিটি স্ক্যান দেখে কতটা সঠিকভাবে বলতে পারবো, তার সুস্থতার অ্যাচিভ করার হার কতটা, এবং what are the chances that the mortality rate is higher in a patient. This is prognostication, and CT scan plays a very important role in prognostication. Number three is what are the precautions that need to be taken while radiological imaging? What are the precautions that are very important for imaging other than the usual precaution from droplet spread? And finally, we will discuss about the radiological findings, the imaging findings. What are the typical findings of COVID? What are its diagnostic overlaps, and what would be the differential diagnosis? So by now we are all aware that this SARS-CoV pandemic that is ongoing for the last say 9 months, if we have to consider its start date. It's a viral disease caused by coronavirus strain 2, and this virus predominantly causes respiratory symptoms. I repeat, it predominantly causes respiratory symptoms, but that does not mean that it excludes the other organ system. It might present as myocarditis by involving the cardiovascular system. It might present as diarrhea when it involves the GI system, but the primary mode of presentation is usually respiratory symptoms. That is the commonest mode, I must say. Now, what are the symptoms? If we have to list the symptoms based on from most common to least common, I would say fever. 85 to 90% of the patients would present with fever. Next is cough, which is usually dry without expectoration. Dry cough without expectoration. That is the next common clinical feature that patients present with. Then there will be other features like sore throat, anosmia, and ageusia. These are the more commoner features. If we come to there is a considerable degree of overlap of symptoms with other viral infections. Myalgia, lethargy, arthralgia, this can occur in this disease too. And certain out of the respiratory system, certain systems which could be affected is heart. Patient can present with myocarditis. GI system, as I said previously, can be affected, and then there will be diarrhea as the presenting symptom. But these are less common varieties. I repeat, the most common presenting symptoms are fever and dry cough. And with disease progression or more increased pulmonary involvement, there can be labored breathing, shortness of breath, শ্বাসকষ্ট যেটাকে বলা হয় সেটা খুব কমন এই ডিজিজে। অ্যান্ড pulmonary increased pulmonary involvement would result in hypoxia and reduced oxygen level in the blood, and we are all aware, we are monitoring nowadays the SpO2 by pulse oximeter. Now, we have to remember that these are the clinical features of the disease, but not all patients will be symptomatic. A significant chunk of patient will be COVID positive, but they will have no symptom. This is a debatable area whether these patients are spreading the disease. Even WHO is not very concrete on this point, whether this patient is spreading the disease or not. But we have to maintain universal precaution from wear masks, gloves, As we all know, we don't know whether they are spreading the disease or not. So we must be aware that there are a chunk of patients around us who might look healthy, who might seem healthy, but they may be COVID positive, and they may or may not transmit the disease to us. And therein lies the importance of universal precautions. Now let us come to radiology proper. What are the modalities that we are most commonly using in evaluation of COVID-19 patients? Two modalities. Number one, X-ray. Number two is HRCT scan. X-ray is much less sensitive than HRCT scan. But I would stress here that X-ray is extremely available modality. Availability, portability, low cost are very useful in a patient in using X-ray as a modality for evaluation of initial evaluation and for follow-up of the patients. We cannot do HRCT in a patient multiple times, but we can do X-ray multiple times. X-ray is also very easily X-ray is that imaging modality where department can be very easily segregated. It can be used as a portable modality. And it is very important to segregate radiological units for COVID positive patient and those patients who are requiring radiological investigations but not COVID positive into another setup. X-ray is that investigation which we can use, we can segregate very nicely. Now coming to HRCT. What is HRCT? HRCT is high resolution CT scan. How is it different from a routine CT scan? A routine chest CT scan will take slices at a thickness of about 5 mm. But when we do an HRCT, a high resolution CT scan, this slice thickness reduces to 1 to 2 mm. That is why it is called high resolution. How is it useful? Very small pulmonary involvement, which might not span for say 5 mm, smaller than 5 mm, they may be missed in a routine CT scan using 5 mm slice thickness. But these lesions owing to smaller slice thickness will be picked up by HRCT. That is why it is called high resolution CT scan. Now the protocol is a non-contrast high resolution CT scan. I repeat, non-contrast high resolution CT scan. Why non-contrast? Non-contrast is mandatory for COVID imaging because as soon as we administer contrast, there will be some degree of enhancement of the parenchyma, and contrast will interfere with ground glass opacities, the typical imaging feature of COVID. There will be interference in before even the reporting is done. So the primary CT scan should be a NCCT scan, non-contrast CT scan, and thereafter if the need arises, we give contrast. When does such a need arise? The need arises if we are suspecting pulmonary embolism in a patient. There are patients who will show normal HRCT scan, or rather I would not say normal, who would show very less amount of pulmonary parenchymal involvement, but patient condition refuses to improve. Patient keeps on deteriorating, but lung parenchyma clears up. This is an instance where we should suspect there could be pulmonary embolism, and thereby we should do a contrast CT. But we have to remember, before doing the contrast CT, before administering the contrast, it is a must to do a non-contrast scanning if the patient is investigated for a COVID positive pneumonia. So this is about protocol. Now let's talk about the indications. What are the indications? HRCT is not the diagnostic tool for COVID-19 pneumonia. We have to remember that gold standard diagnostic technique is RT-PCR for COVID-19. HRCT is not the diagnostic tool, but it has a significant role in diagnosis. There are cases where patient is strongly suspected to be COVID positive, but the RT-PCR positivity is delayed. and there are respiratory symptoms. These are the patients we evaluate with HRCT. If HRCT shows typical findings of COVID pneumonia, then we can take the patient to be COVID positive. And what should we do? How does it help us? We should do repeat testing. Even if the RT-PCR is negative, the patient is suspected to be COVID positive, but RT-PCR is not positive, we go for an HRCT. If the HRCT shows that there is parenchymal involvement consistent with COVID-19 pneumonia, then it mandates a repeat RT-PCR. Till the time it comes positive, and there are parenchymal involvement in HRCT, we should keep on repeating the RT-PCR. Because in our practice, we have got multiple such patients where RT-PCR comes negative once, comes negative twice, but HRCT strongly suggests it's COVID pneumonia, and repeated RT-PCR ultimately comes out to be positive, even if initially negative. So this is a very important indication we have to remember. Number 2 is evaluating patient with respiratory symptom and COVID-19 for pulmonary involvement. What is the extent of pulmonary involvement? This is another indication. For those patients who do not have any respiratory symptoms but who do have a COVID positive status, what is the indication of doing HRCT? We will do an HRCT when that patient has risk factors for disease progression. For example, morbidly obese patient, or rather a very obese patient, not even if not morbid, a very obese patient with diabetes or with hypertension does not have any respiratory symptoms as of now, but the person is COVID positive. We can do a HRCT scan even without respiratory symptoms to assess if there is any silent parenchymal involvement. This is another indication. And finally, I would say CT will help us in prognostication. As I said earlier, extent of pulmonary parenchymal involvement, the pattern of pulmonary parenchymal involvement will give us a prognosis about the outcome. How? I would talk about it in detail later on. Now, as I said, RT-PCR remains the gold standard for diagnosis of COVID, but HRCT will aid, along with RT-PCR, will result in higher diagnostic yield. Why? Because HRCT is highly sensitive. Even if the patient is asymptomatic, having no respiratory symptoms, HRCT will pick up disease if there is even minimal parenchymal involvement. This is its sensitivity. But why is it not then used as a diagnostic tool? The reason is it is not specific. Sensitivity and specificity are two different medical terms or parameters, I would say, we use very frequently for any kind of diagnostic tests. HRCT is highly sensitive, but it is not specific. Why it is not specific? Because there is a considerable degree of overlap between the findings that we get in COVID pneumonia and in pneumonia due to other viral illnesses or many other diseases, as I will discuss later in the differential diagnosis section. Because of this overlap, the specificity decreases, and lack of specificity results in HRCT not being used as the primary diagnostic tool. So now let's move on to the precautions. We have talked about the indications. Now let's move on to the precautions. Regarding precautions, as in any other COVID scenario, the first precaution we should keep in mind is precaution from droplets, that is masks, face shield, gloves, apron or gown. This is the precaution from droplet spread. But what are the precautions which are very particular for any radiological setup? I would say, let's come to X-ray. As I was saying, X-ray is a very good modality because of its portability. The portable word is very important. We need to segregate units. A patient is coming to the X-ray department for chest X-ray. If that person is COVID positive, then there is chance of cross-contamination and cross-infection to the next patient who is also coming to the department for any other X-ray for any other reason and is not COVID positive. So there lies the need to segregate the unit. If a patient is admitted in the hospital, then he or she should be subjected to portable X-ray. But if the patient is not admitted, this portable X-ray cannot be used. So how can we segregate? We should have auxiliary units for COVID positive patient and separate unit for COVID negative patients. So that is the way to prevent cross-contamination. Next precaution, which is for any diagnostic imaging, is especially for radiology. Whenever we are doing a particular investigation, there should at least be 2 persons in attendance. One person who is responsible for patient handling and another person who should be responsible for cleaning and disinfection post the procedure is over. This also prevents cross-contamination. And finally, we should remember that all radiological equipments or all the apparatus present in the room are essentially solid non-porous surface, and the virus has a capability of surviving for approximately 72 hours or up to 72 hours in such surfaces, and therein lies the importance of cleaning and disinfection post the procedure. This can be achieved by covering the instrument with covers, and once the procedure is done, we discard the covers. And secondly, it can be done directly by disinfection and cleaning after the procedure is done. So in a gist, if I have to repeat the precautions, precaution from droplet, that is applicable for anything related to COVID positive patient in this scenario. Next, the precautions that are particular for radiological unit is we must remember to segregate the units, make the investigation portable if at all that is possible. Number 2 is have 2 imaging attendants, one for patient handling, one for machine cleaning. This should be enough. This is very much required to prevent cross contamination. And finally, after the procedure is done, disinfection and cleaning plays a very important role. Now let's come to the imaging finding. Now, live sessions are suffers the technical drawback of not being able to share images, and only I can verbally communicate. And radiology without imaging, showing images, showing good pictures of CT, X-ray is very incomplete. But anyways, I will try to verbally communicate, to verbally explain as much as I can about the radiological features. Now, as I said, the primary 2 investigations that we are doing for COVID positive patients are X-ray and HRCT. We have to remember that this viral illness affecting predominantly the respiratory system is essentially an atypical or organizing pneumonia. So what we get in imaging, the findings that we get in imaging is the finding of atypical or organizing pneumonia. Essentially, there will be airspace opacification. What is that? The air spaces, the alveolar air spaces in the lung is filled with infiltrates. This results in the black of the lung being replaced by certain degrees of white. Now, 2 primary features of COVID-19 pneumonia are GGO, ground glass haze, and consolidation. Now, what is ground glass haze and what is consolidation? As I said, the black of the lung is replaced by white. We see the lung as black in HRCT and in chest X-ray. This is replaced by white. When this white is less dense and does not result in obscuration of the underlying details, then it is known as ground glass opacity. And when this white is so dense as to completely obscure the underlying lung, that is known as consolidation. These 2 features are very much the crux of imaging finding in COVID. Now, what is the pattern of involvement? The pattern of involvement is very typical: subpleural, basal, multilobar, and bilateral. We have to remember these 4 terms if we have to diagnose COVID pneumonia in HRCT. Subpleural, basal, multilobar and bilateral. Here I mean that these opacities, which is usually first the ground glass opacities, they will make their presence felt in the periphery of the lung, just beneath the pleura, that is subpleural. In the basal zones, that is the most dependent part of bilateral lower lobes. They will have presence in multiple lobes of the lung and they will be seen bilaterally. Any deviation from this pattern should provoke us to think that this is not COVID pneumonia. This is something else. But having said so, I will say that when the disease progresses, this subpleural and basal pattern is lost with diffuse parenchymal involvement, which could range to the extent of absolute whitewash of both the lungs. But this multilobar and bilateral involvement will be present. Next is lymphadenopathy. Some degree of mediastinal lymph nodal enlargement will be there, but those lymph nodes will not be more than 1 centimeter. Any bulky lymph nodal mass with conglomeration with necrosis should rule out COVID pneumonia. Coming to pleural effusion. Pleural effusion is usually not seen in COVID pneumonia. It is very rare. So, the main radiological finding remains ground glass opacities, consolidation. Along with this ground glass opacities, as the disease progresses, initially infiltrates will fill in the alveoli, the sacs, the alveolar sacs. Then it will proceed outwards with thickening of the alveolar wall. This will manifest in CT scan as interlobular septal thickening. So first we get the initial phase, which say lasts for 0 to 4 days. In this 0 to 4 days we get ground glass opacities. Then comes the disease will progress and there will be features of interlobular septal thickening when the alveolar wall is thickened. Then proceed to the peak phase. After the progression, proceed to the peak phase when we will get consolidation. And finally, after 14 days, there will be the phase of resolution. So what is the message from this? Message is consolidation will never appear in the initial disease onset. At least 6 days should elapse from pulmonary involvement for consolidation to make its appearance. The first thing radiologically that will be visible is ground glass haze. Then along with ground glass haze, septal thickening will be seen, that is the disease progression. In this phase we radiologically use a term called crazy paving pattern. It is a radiological jargon, not much to look for it. I mean, septal thickening are linear lines or linear small linear white lines we see in CT. When they are associated with ground glass haze, there is a pattern as if a road is making acute twists and turns. This is the crazy paving pattern. After this we proceed to consolidation. So whenever we see consolidation in a CT or X-ray, we have to think that this disease has crossed the 6-day mark. So these are the phases. Now, as I said previously, once again I'll repeat. Suppose we see the CT scan. In the CT scan we see that there is disease resolution, but the patient is not improving. Then we should think of pulmonary embolism. This is a finding that we have encountered, and we must remember, if the CT shows lung infiltrates, alveolar infiltrates to resolve, but the patient is deteriorating, then we should think of pulmonary embolism, and then we should go for CT pulmonary angiography. And while doing that, it is a must to make the technician remember that please take the NCT scan before administering contrast. Another pitfall I will just mention here, when we are looking at the CT, other than ground glass haze and consolidation, if we get thick septal lines, which we often get in pulmonary edema, and the patient could be a young patient, why should we get a septal line? We can get septal lines in aged patients where there is already a cardiac ailment, already cardiac function is compromised. But in a young patient, septal lines that are caused by pulmonary edema, if such septal lines are encountered in a young patient, then that should provoke us to think that the patient might be having myocarditis, and the evaluation should then go in that line. So these are certain things we have to remember while reporting CT, like as I septal lines. If you look at septal lines, think of myocarditis in a young patient. Then you look at resolving opacities and deteriorating patient condition, then go for a pulmonary angiogram to detect pulmonary embolism. Remember all these things. And once again I'll repeat, look for the 4 things as I said: subpleural, basal, multilobar and bilateral. Any deviation, any aberration from this pattern in the initial phase of the disease should make us think, aren't we looking at something else, or is it really COVID-19? Now let us move on to some differential diagnosis. The typical features of COVID-19 I already told you. Now let's come to some other features which we can encounter when we are looking at a pulmonary CT. We can get a tree in bud appearance, small nodules having distribution in the line of bronchovascular markings. This kind of feature is not seen in COVID. Or suppose we say a single lobar consolidation. This is also not particularly seen in COVID. So if we are looking at actually some, say, lobar consolidation, a single lobar consolidation, or cavitation, or significant amount of pleural effusion associated with it, or a bronchus with impacted mucus within, our thought process should immediately channelize to think that it is bacterial pneumonia and not COVID pneumonia. Here I would mention an organism called Pneumocystis xerovecii. This is an organism which causes infection in immunocompromised patient. But the catch is, it causes similar ground glass opacities as in COVID. So how do we differentiate the two? The differentiation comes from the 4 golden points that I said you. The distribution in Pneumocystis xerovecii infection is not basal subpleural. It is a diffuse kind. It can be multilobar, it can be bilateral, but it is a diffuse kind. And it is a diffuse kind with some amount of sparing of the subpleural zones. So just the opposite of that we get in COVID. Though there are ground glass opacities, the pattern is just the opposite. So immunocompromised patients, they are prone to COVID-19 infection, and they can also be infected by Pneumocystis xerovecii. This is like, if you look at the pattern, it might some way help in differentiation. Now, as I said, bacterial pneumonia I have already said. Remember, tuberculosis is a very important diagnostic dilemma for us living in Indian subcontinent whenever we are looking at a CT chest. Whatever we look at, we will give tuberculosis some amount of thought. Aren't we missing tuberculosis? We will always think of that. So what are the typical features of tuberculosis? Tuberculosis can present in a variety of ways. But most commonly, as I said, there will be this small nodules in peribronchovascular distribution pattern, and then there will be large cavities which could be thick walled. There will be extensive consolidation and any pattern of involvement. I mean, they do not usually follow a specific pattern of being subpleural and being multilobar. It can have any pattern, any tree in bud appearance, small linear white lines with the dots like buds around it. That's the tree in bud appearance. This appearance is characteristic of tuberculosis and not COVID-19 pneumonia. And finally, any other viral pneumonias. I must say here that it is very difficult to distinguish COVID-19 pneumonia from any other viral pneumonias. Why so? Because both the entities causes organizing pneumonia and there is no difference in pattern. But we have an advantage. Sitting in the scenario of COVID-19 pandemic, we can essentially take our CT scan image features to be due to COVID-19 than due to any other viral pneumonia as of now, since COVID-19 is predominant and prevalent in this setting. So any kind of diagnostic overlap with other viral diseases, like we can give it a backseat, and for now on we can think this is COVID-19. So what are the predominant differential diagnoses? I'll repeat once again: bacterial pneumonia, tuberculosis, pneumocystis jirovecii infection in immunocompromised patient, and of course other viral pneumonias. So I think radiologically I have covered more or less the imaging patterns and the differential diagnosis. Now let's come to the CT reporting pattern. COVID-19 is a pandemic. It is affecting worldwide. It is affecting multiple patients. So it is very important to ensure that the reporting pattern is standardized and it's uniform. Any reporting done by me in this part of the country should be relatable, should be uniform to any other radiologist reviewing it in any other part, or should immediately convey the same meaning to the clinician. We should not fumble while looking at the report. It could be this, it could be that. Because it's a pandemic, there lies the need to ensure that the reports are uniform, relatable and reliable. And for this reliability and this uniformity, the Dutch Radiological Society brought forward the CORADS scoring system. This CORADS scoring system gives points of 1 to 5 based on the imaging characteristics. There's an additional point, the CORADS 6. The CORADS 6 is assigned to those patients who have pulmonary involvement, features of COVID-19 pneumonia in CT, along with PCR positive status. So we know these patients are RT-PCR positive, so that's CORADS 6. But from 1 to 5, there are various stages. One is those patients who have features of other pulmonary features, not essentially infection and definitely not COVID. So there are features, pulmonary parenchymal involvement other than infection. That is CORADS 1. CORADS 2 is infection due to causes other than COVID. Infection due to causes other than COVID. That is CORADS 2, bacterial pneumonia, tuberculosis, whatever it could be, but it is not COVID. From CORADS 3, we start getting the features which are somewhat consistent with COVID. But even in CORADS 3, we cannot say this is COVID. The findings are equivocal and the risk is intermediate. The risk becomes high when it's CORADS 4. It is highly suspicious. The pulmonary parenchymal involvement pattern are highly suspicious of COVID infection, and that is CORADS 4. And we give CORADS 5 when we are more or less certain this is COVID, but we don't have the PCR report in hand. So that's CORADS 5. So this is CORADS 1 to 5, which more or less tries to give a uniformity to the reporting pattern. There's another CT scoring system which is called the CT severity scoring. As I was saying previously, CT scan can be used to assess the prognosis in a patient. What is prognosis? Prognosis is what will be the outcome of the patient. How will the patient fare in this COVID warfare? That is prognosis. And how is CT helping us? This scoring system will give a certain number to the patient. CT severity score of 1 or 0 to CT severity score of 25. 0 is no parenchymal involvement to 25 is maximal parenchymal involvement. And how do we find it out? We know that there are 5 lobes in 2 lungs of ours, and a particular number is given to each lobe. This number is given based on the percentage of parenchymal involvement. And finally, we make a sum. We add up the total score that we get from these 5 lobes. And that gives us the final CT severity score. How will CT severity score help in prognosis? Higher the CT severity score, higher is the chance of mortality. And it is seen that this has a sensitivity of 85%. CT severity scoring predicting mortality has a sensitivity of approximately 85%. I will repeat here that patients having consolidation and patients having a high CT severity score has a high mortality. So this is the use of CT scan in prognostication. So let us summarize whatever we discussed in this last few minutes. In this pandemic situation, radiology is definitely helping out for diagnosis whenever RT-PCR is delayed positive, and whenever the patient is a strong suspicion to be COVID positive but we are not getting RT-PCR report, go for HRCT. If HRCT says it's very likely to be COVID, like it's CORADS 4 or CORADS 5, then have the RT-PCR repeated. It will definitely come out. From my experience, I can say it will definitely come out to be positive after 2 repeats. It will come out to be positive if HRCT is telling you it is CORADS 4 or 5. Now we have to remember the pattern for identification of CORADs. I'll repeat once again here. Ground glass opacities and consolidation, these are the two primary pillars in the diagnosis of COVID pneumonia. Mediastinal lymphadenopathy and pleural effusion are not so common. And when you're looking at GGO and consolidation, look for the pattern. It will be bilateral, multilobar, subpleural and basal. But this subpleural and basal, these two entities will merge, will vanish, or you can't separately differentiate them late into the disease when the disease has progressed and when there is diffuse involvement or whitewash lung. But this is the pattern when you are looking at an early CT scan. Now remember, HRCT is not the diagnostic tool, it's not the gold standard because it lacks specificity. We cannot differentiate it from other viral pneumonias or many other disease entities as I discussed in the DD. It is not so specific, though the sensitivity is high, owing to lack of specificity. It is not the diagnostic tool. The diagnostic tool remains RT-PCR. Okay, but both the tests done together, yield is much higher. And remember, whenever we see consolidation in a CT scan, we have to think the disease has progressed. This is the peak phase of the disease, and at least 6 days must have elapsed from the disease onset. Remember, while doing CT scan, it is a must to have the non-contrast CT scan done prior to any contrast administration, if that is at all to be done. The CT scan that is done is a HR CT scan, high resolution CT scan, and we have to follow the precautions as I said previously. Precaution from droplet, precaution from cross-contamination by segregating the units and by having 2 assistants in the department or 2 technicians in the department, and of course post-procedure cleaning is very important. So I would conclude my talk here. Thank you. And next at 8 p.m. Dr. Shongita Pal will be delivering her live talk on strains of COVID and reinfection. Kindly stay tuned till that time. Thank you.